Andrew Schorr on location in Chicago as we're attending the 2010 American Society of Clinical Oncology meeting, ASCO. 30,000 doctors here going day and night. As they discuss cancer, one of the most daunting cancers, and unfortunately all too common, is lung cancer. But as we learned in an interview with Dr. Corey Langer from Penn Medicine's Abramson Cancer Center, there is at least a glimmer of hope for a subset of patients with lung cancer and promise as we look towards the future.
This has been a very exciting meeting. Probably one of the most important presentations is a plenary paper on a unique molecular abnormality that we see in lung cancer called EML4-ALK. ALK stands for anaplastic lymphoma kinase, and you'd think by the name of it would have something to do with certainly not lung cancer, but lymphoma or liquid malignancies. But in fact, it's an enzyme that helps promote tumor growth, and when this particular gene fuses with other triggers and molecular pathways, it can promote very aggressive tumor growth. And there is a specific agent, it now has a name, it's called crizotinib, also known as PF02341066, but now that it has a name, it's much easier to use that, which has been tested in early phase drug development, phase 1 dose-seeking studies, phase 2 trials that are specific for a particular diagnosis, in this case advanced non-small cell lung cancer. And this drug seems to be very, very active. About 1 in 20 lung cancer patients harbor this translocation, this particular marker. When we look at never smokers, that figures closer to 20 or 25%. So it's not an insubstantial number overall. If we do the math, 220,000 people a year are diagnosed with lung cancer, so 5% of that, still 10, 11,000 people. That's equal to the incidence of esophageal cancer overall, all stages. So the public health impact of this is still quite significant. The progress that we make in lung cancer never occurs in one fell swoop. It's all incremental baby steps, but each baby step along the way is real progress, and it makes a difference in patients' lives. For the first time, we have an elderly-specific trial that shows a statistically significant, and I would argue clinically meaningful survival advantage for the two-drug combination, the platinum-based combination versus the single agent. And frankly, the rest of the world needs to know that more than half the patients we treat are 70 years of age or older. Lung cancer is very much a geriatric illness, and these folks, unfortunately, are underrepresented on clinical trials. A lot of the breakthroughs that we make have never really filtered to the elderly. And it's clear that the elderly, if they're fit enough, can certainly tolerate relatively aggressive therapy, and that therapy in turn will make a significant difference in both their longevity and also their quality of life. So I'm very excited about this in large part because a good deal of my research is focused on the elderly. I think Penn has a unique position. We are witnessing the wedding of technology and biology. In locally advanced non-small cell, for instance, we are just about to initiate protocols looking at proton beam radiation that will help limit the exposure of radiation to normal adjacent tissues, and in turn hopefully enable us to escalate the doses that we can give to locally advanced lung cancers. We'll be giving this with standard chemotherapy. This will be an ongoing effort probably over the next 2 to 3 years for eligible patients whose disease is locally advanced, cannot be taken out surgically, but also has not exhibited any spread beyond the chest. Our our combined modality group, interdisciplinary thoracic group, Penn has been an exciting time for me. I've been here now 2 years. There are 7 dedicated thoracic surgical oncologists with whom I work, 4 dedicated thoracic radiation oncologists, at least 4 dedicated pulmonary oncologists. I'm aided immeasurably by my medical oncology colleagues, Tracy Evans and Jamie Stevenson, who are leading a number of protocols, and it's just an intellectually enriched environment that I think will help hold the key to clinical advances in thoracic oncology, particularly in the Delaware Valley. We serve over 7-8 million people in our geographic region. So I think we are entering the era of personalized therapy, of customized or individualized care. Previously, particularly in advanced non-small cell, we had a one-size-fits-all approach. We used the same chemotherapy combinations in very disparate populations and patients with very different clinical characteristics. Now we are melding those clinical characteristics with molecular markers that will help drive our therapy and help determine on a patient-by-patient basis what is the optimal approach for each patient. When we do this, and we do it intelligently, I believe we can clearly improve overall survival rates. Even in advanced disease where cure is not really a reasonable prospect, will enable patients to live longer and live better.
Some signs of real progress in lung cancer. Here's hoping over the years to come with personalized medicine, there'll be a lot more. In Chicago, I'm Andrew Schorr.